All right, so good afternoon, everyone. For those of you who don't know me, my name is Bilal. I'm one of the PGY3s, and today I'm going to be talking about emergency department observation and some alternatives
Bilal, I
to
don't think we
admission.
can hear you.
Oh,
We can hear him.
We can hear him.
again?
Yeah, I hear you.
Okay, cool. Um, so just a brief outline. Today I'm going to be covering emergency department overcrowding, the benefits and downsides of having an observation unit, some rules about Medicare and observation units, and I'll go over some of our observation unit metrics. So every year there's roughly 120 million visits to the ER. This is about one for every three people living in America. And this group of patients coming into the ED represent about 50% of the amount of admissions that we have to the hospital. This is an increase from roughly 30% in the mid 1990s. As our population continues to grow and the amount of elderly that we have continue to grow, it's essentially creating a surge for inpatient beds that we do not have. Um, ASEP defines overcrowding as a situation that occurs when the identified need for emergency services exceeds available resources for patient care in the ED, hospital, or both. And we should care about this because it leads to increasing amounts of people leaving without being seen. It leads to delay in potentially life-saving care and increased length of stay overall, which is associated with increased morbidity and mortality. And when we have more borders in the ED, this leads to longer wait times for CT, blood draws, and medication administration. There have been a lot of proposed solutions to this problem, one of them being emergency department observation units. So the typical ER is designed to care for a patient for around 6 to 8 hours, with the length of a shift being around 8 hours in most places. However, some people cannot be safely discharged within that time frame. These people are usually admitted to the hospital. However, some people who are admitted to the hospital do not need a prolonged stay and can be safely discharged within 24 to 48 hours. Observation units are essentially great for these people who just need some more time, but can safely be sent home or to a subacute rehab or something similar within 24 to 48 hours. There's four distinct types of observation units. The first type of obs unit is kind of like the one that we have at Kings County. These units are protocol driven and they are in a dedicated observation unit. By protocol driven, we mean that there are certain rules and guidelines dictating how you should care for patients on observation and dictating which patients should be placed in an observation status. These units are usually located within an ER or adjacent to it, and they are generally closed units, meaning only a certain group of providers can place patients in the unit. They also usually have dedicated nursing staff and either ER doctors or NPs and PAs caring for the patients there. The advantages of this type of unit is that they have lower admission rates, lower length of stay, and having a dedicated group of doctors leads to a more streamlined care in a timely manner. A disadvantage of this is that having a whole separate unit and space to put these patients in can be very expensive, especially for smaller hospitals who are often not at full capacity. Type 2 units offer discretionary care. They also are in a dedicated OBS unit. By discretionary care, I mean they don't follow a specific set of protocols. These units are referred to as open units because doctors from various specialties can place patients on OBS in these hospitals. A disadvantage of this type of unit is that it can be hard to coordinate care with a variety of different providers as opposed to having a smaller dedicated group. Type 3 units offer protocol-driven care, but their beds are in any location inside the hospital. That's why they're often called virtual units because they don't have a dedicated space. So these units will have different doctors managing patients depending on their location, whether it's an ER doctor or an internist, but they're usually both aware of the protocols surrounding the patient. Type 4 units are the most common type of unit. They are not protocol based and they have patients boarding in any location inside the hospital. These units have some downsides because the patients are often treated similarly to inpatients, and it's kind of hard to train the staff to be aware of which patients are inpatients and which are OBS because they're all in the same place. The best evidence is for protocol-driven emergency departments. These units have a 17 to 44% decreased likelihood of admission following observation status. They also have 20 to 40% shorter lengths of stay and can have up to $1 billion in annual cost saving. Medicare defines OBS as a well-defined set of specific clinically appropriate services for the short-term treatment and assessment of patients to decide whether they need to be admitted or they can be discharged home. Medicare expects OBS to be around 48 hours or less, and only few cases should span beyond that time frame. A lot of private insurers are also using similar language. I think something important to highlight and that we should all be aware of, since we're definitely going to be working in OBS units in our career as they're only going to continue to grow, is that patient a patient with Medicare on observation can have a significant economic impact on that patient. So an average Medicare inpatient is liable for an $1,156 deductible without any coinsurance. If you place that same patient on OBS, they have to pay a $140 deductible per year. But each different service that they get on observation, they're liable for a 20% coinsurance on each service because they're being billed as outpatients. So whatever it is, whether it's blood draws, EKGs, chest X-ray, they may be liable for up to 20% of each different thing that you do. Drugs may also not be covered in observation care as they would be if a patient had a full admission. Um, the most impact of this is going to be with patients staying like around 48 to 72 hours, and they can have increased costs up to $1,300. This probably doesn't sound like a lot of money to it is a lot of money now, but it won't be in a couple of years. But if we look at it from the scope of someone on who has Medicare, 70% of these people are 300% below the federal poverty line. So that would equate to about $45,000 for the average Medicare couple who is married. And $1,300 would be almost 3% of their gross income. So it could have a pretty significant impact on them. I looked at a study that examined OB status in around 700,000 people in almost 1,000 hospitals. And that data showed that while most encounters are under 48 hours, around 8.8% can be longer than that. So the cost sharing does have the potential to impact a lot of people. Something else that I never really thought of was that when we're placing a patient on OBS for subacute rehab, if they end up requiring a nursing facility instead of subacute rehab, the days they spent in observation care are not going to go towards the required 3-day stay that a patient must have prior to Medicare paying for a nursing home. So you have to have 3 full days as an admitted inpatient for Medicare to then go ahead and pay for a skilled nursing facility. The days that you spend in observation will not count towards that requirement. Another really important thing is that if you are admitted within 60 days of being in observation care, you are still liable for that $1,156 deductible. However, patients readmitted to the inpatient ward within 60 days do not have to pay a second inpatient deductible. And about 20 to 25% of Medicare patients have this readmission within 60 days. There are a lot of benefits on the hospital end for having an observation unit. One thing is that OBS rooms are smaller. You can kind of see with our OBS unit, you kind of just need an underused space inside of the hospital, and you can separate beds by curtains because the hospitals don't really have the requirements that an inpatient bed needs. They also have lower nursing requirements. Medical and surgical floors are usually staffed in a standard ratio, but observation patients don't need that ratio because they have much less needs and they've been pre-selected to be much less acute patients. When you follow pre-specified algorithms on these OBS patients, it generally equates to lower costs with similar outcomes. That's something else really interesting that I found was that Medicare is kind of widely recognized to not fully cover average inpatient hospital costs for a lot of common diagnoses. CHF is one of them. So a lot of the times when the hospital admits a patient for CHF, they are not being reimbursed the amount that they're actually spending for that patient. So if you go ahead and place that CHF patient on observation, you can avoid the hospital having to deal with a financial loss and kind of create value for your obs unit in that way. Something else important to consider is that if we admit someone to the hospital and they're discharged in less than 48 hours, Medicare recovery audit contractors may go back and try to get that money back that they paid for that admission. And on the flip side, denials for up status are very rare. If you look at this chart, it kind of shows the average cost to manage some common things that we see on OBS versus if that patient was admitted to the hospital. For chest pain, we see that it's a few $100s cheaper, and you have a pretty dramatically reduced length of stay with similar outcomes. With TIA, you can see something similar. It costs a lot less, and you have patients staying 26 hours versus 60 hours. Shorter length of stay also allows you to have higher turnover, move more volume through an obs unit, and kind of clear the ED from overcrowding. So when you think about who a suitable patient is for OB status, there's actually a good amount of data supporting which patients are kind of like the best candidates for this. And one of the most tried and true uses of an observation unit is like placing patients on observation for chest pain or rule out ACS. And a lot of places are going to have an algorithm that dictates which patients are low risk enough to be in the OBS unit. For us, our inclusion criteria is someone presenting with chest pain and having a heart score of 4 to 6. And the exclusion criteria will include concern for STEMI equivalents on EKG, vital sign instability, and heart score greater than 7. Most other places with dedicated units will also kind of follow like similar rules that we do. In terms of asthma, the data also suggests that asthma can be treated in an ER observation unit at a lower cost with similar outcomes and in a much shorter duration. I looked at one study that said about 80% of patients who failed therapy in the ER after 4 hours can be safely discharged after 12 to 24 hours of continuous therapy. CHF is another really big one. This is something that we see admitted to the hospital around 800,000 times a year, yet only a minority of these patients are severely ill as a result of myocardial ischemia, fluid overload, or cardiogenic shock. Most of them do not need any invasive diagnostic testing or therapeutic procedures, and all they really need is decongestion, and they can be safely discharged after a brief period of observation. When you have an observation unit or when you're in charge of running one, it's very important to look out for like a lot of key observational variables. Some of the main ones being occupancy rate, the length of stay rate, and the amount of patients you are discharging to home versus the amount of patients you are admitting. It's important to be on top of these numbers to make the unit more efficient because a more efficient unit will be more profitable and can help finance free care for patients who can afford it. And it can help remove more volume from the emergency department, making it less congested. In terms of discharge to home and admission rate, you should aim to be around, traditionally, you should aim to be around 20%. If you're much higher than 20%, you may be observing a population of patients who are too sick. And if you are much lower than 20%, you may be observing patients who are too well and could have just been discharged home. This chart shows the most common diagnoses that were placed on our observation unit for the month of August. The most common one in August was actually trauma, and then inability to ambulate, chest pain, and asthma. Trauma just probably has to do with the fact that we see more traumatic injuries in the summer. This is some of our data kind of from 2022 up until this summer in 2023. We see that our admission rate has, for the most part, in most months, hovered around 20%, which is ideally where you want to be. We see that we are around 30% with patients who are staying greater than 48 hours, but our average length of stay is pretty good at around 43 hours. This chart just shows which patients historically have stayed longer than 48 hours. And I think it's pretty obvious to see that the ones that usually stay a lot longer are the social patients and the ones who are on obs for inability to ambulate. And a lot of times this is just because it can take longer than 48 hours to get these patients placed on SAR. Some of the lower length of stays are the kind of more tried and true uses of the obs unit, like we talked about, like with chest pain, CHF, and syncope. So in summary, ALBS units can be great to help reduce overcrowding. The best evidence is for protocol-driven type 1 units like the one that we have at County, which is why I think it is important to always try to be aware of the protocols and stick to them when you are trying to put a patient on OBS. OBS units can be great for a hospital's financial health in more ways than one. Uh, just be aware they may lead to increased cost sharing for Medicare patients, and it's important to track and monitor metrics to always assess for areas of improvement. These are my references. Any comments, questions?